one of the things we do have here since April 2021 is a centralization of genomic testing into 7 genomics laboratory hubs. And this, of course, is a fantastic idea. You know, nowhere else in the world has that been attempted. And I guess if there was anywhere you might try to do that, it would be somewhere like England. And this is England, not the UK. It's only England, because we've got a relatively small country geographically with a lot of people in it. So it's nicely set up for centralization of that sort. It would be very different if you tried to do it in the United States. It's a huge country. So the logistics should be straightforward. It's a laudable aim. It was established or planned on the back of the 100,000 Genome Project, which was a research project. And I think everybody was generally not merely supportive, but very excited. However, like many very major centrally run and politically driven projects, it was underfunded. It probably wasn't quite ready to go at the time it started, but then there's never a good time. And although it's brought some tremendous advantages, the most obvious of which is ease of access, and access for everyone, equality of access, consistency of technology, easy quality control, and of course enormous acquisition of data. It's been slow. The pathways which are required to make it work are still rather clumsy. They differ geographically from area to area, and it's probably not, as we speak here, as of July 2022, at the point at which we would like it to be. But it's still a laudable aim. So that is clearly the future. Sequencing is the future technology. That doesn't mean there isn't a role for single gene testing and more basic techniques like immunochemistry and fluorescent in situ hybridization. Of course there is, because as I mentioned earlier, if about 30% of our specimens are inadequate for sequencing, having a sequencer there is irrelevant. You still need a different technology, an alternative technology. So we need all those other techniques so that we can make sure that even a specimen from a tumor, from a patient which is inadequate for sequencing, can still have the very most eked out of it. So you see, it's a complicated business, isn't it? So we have a pathway, an established pathway. Could be more efficient. Hopefully it will be. We need to make sure that there are fail-safes around that. We need to make sure people don't slip through the net. But generally speaking, despite the caveats and the problems, which were, I guess, inevitable, we're still in a very fortunate position here. My hope is that the necessary investment will be made to make what in principle is a fantastic idea work, and work well, and work quickly enough, and for most patients, so that it becomes really an exemplar for the way we should do this. That, optimistically, is where I see us in another 12 years' time, because these targets that we are now testing for and the drugs that are developed to exploit them, these will increase, no question. Every time we come to a meeting like this, there is another one. And this will continue. We know that. It's inherent in the biology of not only lung cancer, but many, many tumors. So that's where I think we will be. That's where I hope we will be in 10 or 12 years' time.